All right, I think we are already live. So let me take this opportunity to say hi. Hi, Sean. Nice to see you here. So hi to everybody. This is the first of a series of smart talks, which we've organized once every week. And hopefully by the end of the year, a lot of good information should be curated in one place to benefit those who are interested in abdominal wall surgery. So let me introduce Nimisha to you. So Nimisha, please take over.
Sorry, just 1 second. Yeah. I'm just having a little bit of a network problem. Yeah. Hi, everyone. It's great to be here, moderating this talk on this Saturday afternoon. And as we know, it's on mesh complications, and we have two speakers. Dr. Jignesh Gandhi is from Mumbai, and he will be talking about mesh explantation, take it out. Whereas Dr. Charlotte will be speaking on leave it in, keep it. And our expert commentator is Dr. Sean Orenstein. And on the panel, we have Dr. Rakesh Mohan Kattar from Delhi, and we have Dr. Danny Rosen.
And we'll have Rod Jacobs from Australia.
Great.
Okay. So let's have Jignesh take over. Jignesh, it's all yours.
Yeah. Good evening, everybody, and a special thanks to my overseas colleagues, Dr. Charlotte from Cleveland and Sean also from US. Good morning to both of you. And Sean, a belated happy birthday to you. I think it was 4th of August, if I remember correctly. And also a special hi to Danny. We are waiting for Rods to join us from Australia. This is going to be an interesting session, and my talk is going to be into two different parts. The first part is going to be about my take on take out the mesh. And then the second is going to be a case scenario where we are going to discuss about with the eminent panelists and everyone around us. So I will share my screen now. So I hope everyone can see my screen. First of all, happy Independence Day to everyone in India. And it happens to be a very proud moment for all of us, especially in the times of COVID today. I have no disclosures for this talk, but I am a faculty for Johnson & Johnson, Bard, and several other companies for surgical education. So this was a lady who prompted me to come out with this talk. So this was a case where she had this large hernia following an online only repair, and what was seen was this exposed mesh. She was 1 year post surgery. She went to 3 centers of different tertiary primary care, and all of them advised her that she just needs to do dressings. Now, this kind of a patient, when it comes to you, you start thinking as a surgeon that what you should do and what should be the next option of treatment the patient should be having. So this is where you can see the exposed mesh. As for all of us, one day in the OR, we have a lady patient, say with a previous C-section and a hernia. And intraoperatively, there are a lot of adhesions and there is an enterotomy. We've all gone through a scenario like this. Either we have seen one in the OR or we have probably done one. And then the question comes up, a small or a big hole, spillage, what next? Because all these are very, very arbitrary definitions and we don't have a clear-cut guidelines about what exactly that means. And then the important question in a scenario like this is either you're going to mesh this patient or you're not going to mesh this patient. And then subsequently, the whole chain reaction starts. And the second scenario which we face as a surgeon today in our practice is, can we as a surgeon choose what we want? Say I have a case of ventral hernia for a repair, maybe an onlay or a lap. There are choices available in the market, right, from polypropylene or composite or polyester base or EPTFE, PTFE. And is it possible as a surgeon that whether we can choose the mesh, because the selection of the mesh depends on maybe the surgeon's choice, maybe the company or the hospital logistics, because not all of us are privileged to exactly know and what we are going to choose when we can. So I begin this talk. This is our Indian flag, and I'm going to take you through mesh science versus the surgeons. And obviously, then we will have the second part, which is going to be on the mesh complications, and it will be a case-based discussion. I am a AWR surgeon based in India at say GS Medical College. I'm an additional professor in surgery over there. So if you see today, when we have implanted the mesh, the fate of it is either if the patient is going to become all right and go away, or you can have a mesh infection or a mesh explant. Next is mesh salvage, which is now slowly coming up. So I'm sure what has happened is that we have gone beyond this triangle, and slowly there's an offshoot. I'm talking more and more about mesh salvage, which obviously we will hear from the other speaker. But my talk predominantly is going to move between the mesh infection and the mesh explant. In mesh infection, if you see what happens because of the mesh infection, today we have a morbidity that the patient has to undergo another procedure. There is an impaired wound healing. There's a functional loss of the abdominal wall if the mesh infection is to a larger extent. And there is an extended hospital stay. And more importantly today, medical legal issues. So we are all worried about this frightening complication when we go through as a hernia surgeon. This is an interesting diagram about how, what happens right from the skin to the muscle and how a hernia surgeon thinks about managing a patient. 60% of the infection in the mesh, they come from gram-positive infections and this come from the skin, while 30% of them are gram-negative infection, which come from several other reasons, right from the procedure, what you're going to do. If I place a mesh in this plane, or if I place a mesh into this plane, or if I place a mesh into this plane at different levels, is it going to happen that my infection rate, because the skin is more closer, is going to be more if I'm in more proximity to the skin, or it's going to be less if I'm going to be away from the skin? But today you see that even an IPOM gets an infection. So it is not always true that we will have an infection, but it keeps on changing due to several other dynamics. Look at the CT scan of a lady patient recently seen by me. My arrow is pointing towards the distance between the skin and the fascia. And as we go through, we will see what is happening. So you can see here, as I go through down on the CT scan, this is where the hernia starts. And okay, I have plans in my mind, but you can see that she's got a huge rectal divulgation. And as I go down, suddenly you can see that this lady has undergone a previous surgery for which there was a grafting done. And I planned that maybe I will do some component separation or maybe an IPOM because she has got a big graft in between. She's got too many risk factors. So as I come down, look at this. The graft now comes into the picture. And this is the area where she has a skin graft. And look at that, just about 3 or 4 centimeters below the hernial edge. What is happening is the graft is completely fusing with the skin. So now, whatever kind of an intervention I'm going to do this, like an onlay repair, this can be a disaster for this patient. If I'm going to do an IPOM repair for this patient, that is going to be a trouble for that. Scola is probably going to be an out. And maybe I'll have to think about some complex component separation technique. But then again, the proximity from the skin is what the surgeon should look at as we see these kind of cases. What are the reasons for explanting a mesh today? It gets explanted because of the infection, either a sinus or pus formation. The second reason for explant is typically in an inguinal hernia where the patient has got an inguinodynia. The third scenario where you can get an explant is, say, for example, you are doing a post-IPOM recurrence and you're going to do one of the AWR technique. The mesh comes in your way and probably you're going to take it out. Or it is immediately post-op, like a technical complication. And most of the times this happens when you're in the learning curve. And when we go through some of the case scenarios, I will mention about that. And lastly, not but the least, is the lost plane. Many times we have surgeons who are into the learning curve about the anatomy of the abdominal wall, and you get up into a wrong plane. So what happens after a mesh implantation? We start with that. Either you can have a shrinkage there or a degradation or leaching of the chemicals by the body heat. Today, I will take you through the few slides now that once as a surgeon, it's very important that we undergo and see what is happening to that explanted mesh under the microscope. And let me take out some of the key features which I will make you understand the science of explantation and implantation better. So what happens to the mesh when we put in? There is an inflammatory reaction. And macrophages is always they are there to fight with the foreign body, which is the mesh. Surprisingly, what also happens is there is a liberation of a lot of metabolites along with that, which goes on from months to years. But most important to remember, which I read was very interesting, is as we have inflammatory reaction happening, the surrounding tissue starts getting damaged more and more. Now, this is very interesting in hernia is because you're trying to make an area of weakness stronger by putting in a mesh, but you are trying to balance the pendulum by having a surrounding area which can become weak and more prone for hernia formation, and then non-specific damages to the tissues. So this is a typical case where you can see that this is an implant, and predominantly around the mesh, you can see the macrophages which are loaded around in that area. That is again a zoom picture to show you the presence of macrophages. Mesh integration and scarring. So when we put in a mesh, there is a clotting fluid layer which ultimately develops into a granulation tissue around that. You can have two issues. You can either have a repair or a rejection, which is an ongoing process. And around the mesh, you will have two layers. One is an inner layer, which is a layer of inflammation, and the outer layer is a layer of scar. And it is between these layers, you have trapping of the bacterial organisms, what we also call it as a biofilm. We will talk about that a little later. And then you have the fibroblast laying, which then turn to myofibroblast. Now, these are the ones which cause the contraction of the mesh. So it all depends on what kind of mesh, what way, what inflammatory reaction. The more the myofibroblast, the more the contraction. And you see in the literature, the contraction rate is anywhere from 8%, which can go up to 40%. And this can be one of the reasons for your rolling of the mesh, pain and discomfort. So this is during the implantation. You can see this yellow thing represents the mesh or the implant, and that is a granulation tissue. In the healing stage, you can see two layers there. There is an inner layer, which is of the inflammation, and the outer layer, which is the fibrous capsule. Now, this is the one which actually forms the scar when we have a mesh implantation. So, for example, if you're using in a macroporous mesh versus the microporous mesh here, in a macroporous mesh, what happens is over a period of time, this layer starts getting lesser and lesser, and then you can have more tissue which integrates there. And this is very good and favorable for the patient. While in microporous, what happens is that the in-between bridging area always remains, the inflammatory layers get more and more stronger, and you can have a formation of what is known as a scar plate. Here you will form a scar net versus you will form a scar plate here. And I will be talking a little bit about folded mesh because this is what we used to do. I still remember during my residency days, we used to have a piece of mesh, and at the end when there used to be an extra mesh, we used to be always told that just fold it and stitch it up there, and we will see what happens because of that. Let's talk a little bit about the tissue innervation. You always know that mesh is also known to cause nerve injury, and it is because of the axon disruption. It can either get trapped, or the nerve can get distorted, or it can pass through that, and there'll be pain at odd sites. Now look at this. This is what typically happens to mesh and the nerves. In a macroporous mesh, you can see that there is a big gap. So even if you have an entrapment of the mesh, nothing happens there. But as you come downwards, you can see that the nerves start now joining each other here. And in a typical microporous mesh, what will happen is you will have entrapment of the mesh, or there will be crisscross connections. So you will have points of trigger where the patient will have a lot of pain, and there will be points where the patient will have no pain. But unlike that, look at the macroporous mesh, you will see that the things are totally different. Now coming to this scenario, which also shows you about the mesh ingrowth, the brown one represents the nerve. This is typically an area where you can see, this is the first slide where you can see the nerve and the blood vessels around the mesh. The mesh represents the yellow circles. Then you have the second scenario where now the two nerves are trapped between the mesh particles. So you can see this is typically a patient where he has severe pain because of the trapping of the two nerves. This is a scenario where you will see that one of the nerves have got spared and it could make its way through this mesh, and that's the reason the patient is very, very comfortable. And this fourth one is a scenario where you can see the sandwiching of the nerves between the two filaments. Mind you, this is all happening under the microscope. So as a surgeon, when we have explanted the mesh, I would always request that we should go back into the labs and see these things so that we can understand what exactly has gone wrong with the patient. This is another scenario where you can see the mesh migration, and where you can see the nerve, it's found a way over it, and that's where the entrapment is happening. So this is again an area where there is a mesh migration towards the muscle, and that's because of the myofibroblast, which I talked to you earlier on. And this is again a scenario where the mesh can cause a nerve distortion, and this patient will typically land up with a neurogenic pain. Coming to this neuroma formation, you can see that this is typically a neuroma formation because of the sandwich of the nerve between the two mesh. And clinically, how it is important is the dermatome mapping. So this is one of the clinical indications where we know that the circles represent normal sensation. This is a painful area, and the minus represents a numbness. This was developed by Rigo Alvarez and then popularized by David Chen. And I see a lot of centers abroad in the US using this. And in India also now we have started using this very, very successfully. Very quickly, just to going through the dermatome mapping, we all understand that we have three important nerves in that area: the iliohypogastric nerve, the ilioinguinal nerve. There is always a crossover there. And then you have the genital branch of the genitofemoral nerve. So as a surgeon, we need to understand the dermatome mapping properly. And we also need to understand about the SIN syndrome, where it is slow in onset, progressive and unrelenting. There is a micro compartment present, and the micro entrapment can happen in 90% of the cases. The reason why we are discussing about the nerve hernia repair is because this can be one of the reasons for developing an explantation of the mesh. So what are the principles as a surgeon we should follow? Try to preserve the nerve whenever you can. Cut sharp if you're in doubt, because if you're going to cut it in a brutal way, then they will be leading to a painful neuroma formation, which we saw under the slides. Embed the end into the muscles. Don't keep them bare. Try to put them into the muscles, because the moment you put them into the muscles, you will not have any painful trigger points. And pain mapping post-op is very, very useful. I came across one article where in trying to differentiate between on the VAS score in a patient with an inguinodynia, if the score is less than 6, most probably it seems to be a nociceptive pain. But if it is more than that, it's because of the neural entrapment. And that's how the clinical decision becomes very, very useful. A very nice algorithm propagated by Professor Rigo. Coming to the second part about the mesh and the urinary bladder. So this is something very interesting. So what happens is there is something which is known as mesh folding or curling. It can happen primarily because of the intraop or perioperative reasons, or it can happen secondary, which happens slowly after the tissue ingrowth. Let me tell you what exactly happens. So in the primary, the mesh gets folded because you're not cutting the corners, and then you're laying an extra piece of mesh over there in that area, and it is over for the size there. The mesh which are easily folded are the soft, lightweight mesh. So on one side, the science tells us that macroporous mesh or a lightweight mesh probably would be good. But I think you have to balance it out that it has to be a macroporous mesh, not necessarily lightweight, because lightweight meshes are very easy to fold, and I will show you with some nice pictures. And mesh folded, which typically happens post-extubation, patient has got a vigorous cough, or you make some kind of an untoward movements, and then you can have a folding of the mesh. So the mechanism is that the core muscles contract and relax. The bladder descends because most of the times we have put in a Foley's catheter, and that's where the bladder is decompressed. We put in a mesh there, and typically I'll show you what happens when we have not put it properly. And then post-operatively, the patient has got bowel movements, which also affects the mesh, and so on and so forth. And abnormal movements by the patient. So sometimes a lot of us are enthusiastic in sending our patients back home. We tell them, okay, you can start doing your activities. But mind you, in groin hernias, one has to be very careful. This is a graphic representation to show you that what exactly we do when we put in a mesh. That's the Foley's in the bladder, that's a bladder compressed. Now imagine this patient has got a distension of the bladder post-operatively since you have not put in a catheter. This is what exactly happens with the mesh at that time, if it is not in the right plane. And typically when the mesh is, the bladder is going to get decompressed, this folded component in a mesh which is very, very light remains there, and that propagates over a period of time, and it can lead to a very bad scar formation, more doubling, and formation of a meshoma. This is one of the nice pictures, depicted by one of my residents, Dr. Virendra. You can see that this is a mesh which a surgeon has put early on in his career in a TEP or a TAP, and you can see it's not properly going across all the areas where it needs to be. So what can happen? In this patient, post-operatively, there is a distension, and you can see this classically, the mesh is going to get folded. Now, if you have a mesh which has got a property where it's not going to bounce back in its own place, this folding of the mesh is going to create all the possible complications after that, and that can lead to further sequelae. This is another area where I called it as a sail in the wind phenomena. This is a mesh where there was a large direct hernia. The surgeon has put in a mesh, but he has not overlapped the mesh adequately beyond the pubic symphysis. Neither he has fixed the mesh. The patient coughs post-operatively. The mesh tends to pop up into the defect. And this is what typically happens with the sail in the wind phenomena. So if you have not tacked your sac, or you have not put your sac into the place, either in the Cooper's ligament or onto the rectus muscle, this is what can happen in your case. So the ideal thing would be something like this, that you would be overlapping the mesh in all the directions and see to it that it is placed well in front of the bladder when you're putting in the mesh, because you do not want the mesh to get folded. So I'm seeing a lot of discussion happening on the AWR forums at what exactly must have gone wrong. These are the phenomena which are described in the literature, and that can lead to the first folding, the second folding, and so on and so forth. This is again a patient where the mesh is placed and the patient post-operatively has got some constipation, there's the bowel movement. Mind you, all these things are described in the literature, and there is a movement of the mesh doesn't remain in the place, and then you have a recurrence which comes up very, very soon. So typically in a lightweight or a large pore mesh, what happens is that you have a scar net formation versus the scar plate, which is very, very good. But you shouldn't forget that the movements of the bladder and bowel are going to be very crucial in this patient, and any untoward movement there can lead to a folding of the mesh or movement of the mesh. More the folds, more is the meshoma formation. But the stiffer the mesh, it will lead to more weakness of the surrounding tissue. So again, if you're going to put in a stiff mesh, more inflammation, the surrounding area is going to become more weaker, and then you can have something which is known as a mesh migration. So it's very, very interesting to understand this concept of how a surgeon has to balance between the light and the heavyweight mesh. The next part is extra mesh, and at the edge, please excise it and do not fold it. This is typically what you can look as happening. So you can see this is a piece of an integrated scar. And what has typically happened is the surgeon has folded this mesh over here. And you can see now this is a typical folded mesh. Now this entire thing leads to nerve entrapment, more myofibroblast. So what will happen is there will be more shrinkage and formation of meshoma. So all this complication typically happens when you have a folded mesh. And typically you can see the outline here. This is what we would not expect. So this extra part of the mesh which is placed in here should be excised. Maybe the mesh should have ended here and surgeon should have discarded this. This typically happens nowadays when we are doing our rectus dissection and putting in the mesh. We have to ensure that the mesh is nicely flattened, because if you don't do that, you may have reasons of problems, meshoma formations, movement of the mesh, and then explantation subsequently. Erosion of the mesh. This is again a reason where you have to explant the mesh. Now, why do the mesh erode or they migrate? There is something which is known as a primary migration. This happens typically because of the large surgical pocket. A classical example is a large direct hernia, say about 3 or 4 centimeters, where you can have a migration and inadequate fixation. So two disasters with that. You can have the sail in the wind phenomena. The mesh can migrate completely into that, or it can get folded. And secondary migration is because of the surrounding tissue. Let me show you this typical. This is a case where it is probably a migration into an IPOM defect, where there was a large IPOM defect. The surgeon has tried to put in the mesh. He has not put it properly, and there is a sail in the wind phenomena. This is typically a mesh where the mesh is off-central. Now, the mesh has migrated over a period of time because of the myofibroblast, because there was off-centering of the mesh. So why today centering of the mesh is so important is because you can have an off-centering, the mesh can migrate, cause a recurrence, and it can become a reason to implant. Again, the same phenomena of the folding of the mesh can also lead to an erosion into the bladder. And this is some of the examples where you can see that these are the tracts of the migrated mesh. These are the striated muscles. This is what represents the mesh fibers. And this is where you can see the tracts where the mesh can migrate into the different areas. This is again a classical example of the mesh migration into the vas deferens. As you can see here, the yellow dots represent, and this is where it has gone into the vas deferens. These are again the microscopic pictures. This is again mesh migration into the fallopian tubes. And coming to mesh and the blood vessels. So having understood about what happens there, major vessels are always spared. This is what the literature says. So many times, I don't know, I would like to have the opinion about the surgeons on the platform a little later, that major vessels are spared in the groin hernia. So how many times would you see a mesh getting trapped onto the iliac vessels? We will discuss about that. Capillaries and small vessels around it are the ones where the mesh can get trapped into, and usually the major vessels are spared. And the distal blood supply always circumvents the mesh. This is what happens typically in the phenomena of the blood vessels. And typically in the vaginal mesh erosion, it happens at the apex because of the less vascularity. This is of importance to the gynae surgeons, where they use a lot of mesh in that area for lifting up the angle. Look at this explanted mesh. Any guess what kind of mesh it is? So looking at the shape of the pores, today probably we can predict that what kind of mesh it could be. And if you see, there's a direct correlation between the porosity. This is something which is known as a textile porosity, and this is which is known as an effective porosity, where you will have the scar formation, the granuloma formation over there with no scar bridge, and the tissue ingrowth, if you say typically, is better for hexagonal pores, a little less for square pores, and a little less for diamond pores. So as a surgeon, if I have to choose in a mesh where I want that it should not get expanded in the future, I'll probably use a hexagonal pore mesh. So the pore size determines the integration of the mesh. If you have selected the wrong pore size, you have a higher chance that your mesh can get explanted. So coming to the next part of it, which is about the mesh explant predictors. Today, if you see, multifilament polyester mesh have the highest chance of getting explanted, and so is the composite. MRSA colonization is again a risk factor, and we talked about the distance from the skin to how far the mesh could be, because 60% of the infection is from the gram-positive. Active smokers, higher chance of mesh explant. And typically, if you have a mesh enteric fistula, this patient can get infection in the mesh, but their chance of getting the mesh explanted are going to be very, very high. If at all you're going to explant the mesh, there is a concept of partial or complete excision of the mesh. Partial excision of the mesh, it predisposes the patient to chronic infection because you're still going to leave some foreign body behind, and there'll be a higher incidence of fistula or hernia recurrence. So by and large, most of the times it is to be avoided. But the problem with the complete excision is that it typically happens in a chronic wound status, and then you can have a lot of collateral damage. So again, as a surgeon, we have to balance when you're going to explant the mesh between partial and complete, because if you're going to do a complete, there will always be a risk of collateral bowel damage. Now, you decide that you're going to do, there are some pearls given very nice by Professor Todd, and he says that the optimization starts right from pre-operative. You will do deep cultures, involve an ID specialist, which is so very important today, a CT imaging to what is going to happen, and the bowel prep is absolutely required. Intraoperatively, you will do a remote access. So try to go from a virgin area, which all of us have been taught, and do a meticulous radiololysis. And the pulse during intraoperative is pedicalized approach. That means dissect from an easy area, come from all around, and then come to the most difficult part. So do not try to focus your interest. Maybe you can put in a small dye inside there, see where there is a communication, come from the periphery to the center, your excision will become more and more smoother. So post-explant, again, $1 million question, whether you're going to do a suture repair or a mesh repair. Now, the primary tissue repair in a contaminated zone has almost 80% of the recurrence. So this is where you stand today, that you're going to have most of these patients coming back. But if you're going to do a multi-stage repair, and you're a proponent of that, you will probably do a clearing of the infection and then decide the plan. But the proponents of the single stage today, because there is a group of surgeons who think that single stage is possible, but they will be more and more use of biological, and even today some meshes like physio mesh and others, where it's a biosynthetic mesh. So you as a surgeon have to decide between these three, looking into all the other parameters what the patient can have. So the mesh has to come out, but then what you're going to do after that is what you're going to decide as per the protocol. And then there is something which is known as a bridged single stage. Because by and large, in most of the times, whenever the surgeon is adopting a single stage repair, it always is a bridge repair. But again, this can stand to a high chance of recurrence. So we have options available after the explant, what to do, but we have to weigh the pros and the cons. Another offshoot which I saw recently, and I'm sure Dr. Charlotte is going to talk in details about that, is the mesh salvage, because this is coming up more and more where you aspirate or drain the fluid collections. You either do a partial or a complete mesh excision, debridement of the unhealthy tissue, a VAC application. But the problem is that these patients are typically on a chronic antibiotic therapy, which leads to immunosuppression locally. Now, this is not what you would expect, because the more you're going to have an immunosuppression locally, you probably would stand a chance that this patient might come back with a recurrence. So can we prevent mesh biofilm formation as a surgeon? There are very interesting case report, and this is a study which talks about impact of diclofenac and ibuprofen on the biofilm formation. So they have studied in 2015 and published in Hernia that the use of diclofenac and ibuprofen today can probably help you against the gram-positive infections and prevent the biofilm. Because once the biofilm is formed, it's definitely going to lead to an infection, which subsequently can lead to an explant. That is what the statistics say. Another concept about the mesh degradation. So if you see today, polypropylene in vitro, what typically happens is it leads all these toxic materials. And then there is oxidation, degradation of this material. But polypropylene in vivo incites more inflammation. So it is not that it is always for that polypropylene is good, but it can incite more inflammation. And it can also lead to a phenomena which is known as a cracking of the mesh, which confirms the degradation. So again, the surgeon under the microscope, you have explanted the mesh, try and see whether you can do studies like this, where you can focus and find out whether there has been any degradation of the mesh, which typically has got an appearance like a bark in the regular or a polarized light. And this area tells you that this mesh has probably got integrated well, but this area here tells you that there has been a degradation of the mesh. Now, this is the reason why your mesh got explanted. And that's the reason why the mesh had to come out. So this is how typically it looks like on the surface. You can see the cracking. And this is typically a mesh which was probably more stiffer, more inflammation, and that's the reason it had to be rejected and it had to come out. So I probably have come out with the conclusion that a typical mesh explant report by a pathologist today should be standardized. And the factors which they should talk about are what kind of inflammatory cells they have seen. So it's always good to go to the microscope, discuss that and mention about that, because if you have macrophages, you know that this is good, there's some active problem which has gone on. If you see more and more of giant cells, then it's probably going to be a chronic problem. Please also talk about the mesh relationship with the nerves, because maybe this information I think could be useful from the medical legal point of view, where the mesh has probably come out because of some pain reason. Then the mesh and the blood vessels, maybe whether you have encountered a major blood vessels, you have removed a mesh in a TP, there was some kind of a bleeding. So the mesh always will, the pathology report will always talk to you about that. Whether the mesh was folded or not folded, because I showed you some of the pictures, but typically you can see that folding of the mesh, which also becomes very useful. And it also talks about the mesh migration, because from the microscopy, you can make out looking at the striated muscles whether the mesh has moved or not. So these are the things which I think a pathologist should report today, and a surgeon should ask for these kind of reports, because this will then make it very standardized, because we just explant the mesh and send it to our pathology department. We just see one-liner report that, okay, the mesh was seen. We never go into the details of all these things. I think more and more surgeons, if we understand the science behind it, probably will be in a better position to treat our patients in the future. So to conclude this part of my talk, 75% of the explantations happen in the first 3 years. So mind you, if at all a surgeon says that my hernia repair is very good, according to the literature and the science, you have to follow up your patient for 3 years before anyone explants your patient, the mesh. 50% of the implanted mesh get explanted. So this is also very, very shocking. That means if you have done 100 cases, maybe 5 out of them are probably going to get explanted somewhere down the line. And the type 1 and type 3 ratio is altered in about 70% of the cases. So that means that most of the times it is a metabolic reason where the mesh gets explanted. 30% of the times, these are other reasons where we can correct and we can attribute to. And also certain things like smoking or a chronic immunosuppression and many others which can alter this ratio, where surgeons can be of help. Important learning point is periprosthetic area always gets weakened due to mesh inflammation. So remember, in trying to make a weaker area strong, you are making the surrounding normal tissue more weak. So you have to off balance, and this is where I feel the concept of overlapping of the mesh is coming up. So if you have a larger defect, the larger the overlap is, because if you have a smaller overlap of the mesh, you are going to make the area beyond that more weaker, and that's where you can have a mesh shrinkage or a mesh migration or a meshoma formation. And smoking obviously will aggravate the existing type 1 and type 3 ratio. So this is what we are seeing more and more abroad. We are seeing centers where are talking about the nicotine levels before the surgery. But I'm recently seeing more papers, and I'll be very interesting to have views from Charlotte about the serum nicotine levels and what is the importance of that today, or are we just talking about a change in the paradigm shift? So with this, I would probably end this first part of my talk and over to the moderators, Dr. Ramana. Thank you.
All right. So that was a very new, very engaging and interesting talk. So Jignesh, you've done great. I'm sure a lot of us have really enjoyed what you had to say. You know, I'm not one to waste time on praise, but you did great. Thank you very much.
Thank you. Thank you so much.
Nimisha, if you're around, please take over. Okay, so I don't know, Nimisha is...
she's not there, it seems.
All right, no
Ramana,
problem.
she is not there.
Okay, that's all right. So we have our next speaker, Charlotte Horne. Charlotte is a surgeon who trained in Cleveland Clinic with Mike Rosen and team, and now she's shifted to Hershey, where, you know, we have our friend Eric Polai. So she's going to start as a consultant in Hershey soon. And so Charlotte is going to talk on mesh complications. Keep the mesh. Charlotte, all yours.
Awesome. All right. First, I'll answer your question, Dr. Jignesh. We used to check nicotine levels on patients all the time, actually preoperatively, and if they were positive, we would cancel them day of surgery. But Dr. Petro, who's part of Dr. Rosen's group, recently wrote a paper that said, you know what, maybe although a lot of the stuff that looked, all of the data that looked at a lot of these databases show that there was a significance, it probably wasn't clinically significant. So we will repair people even if they're actively smoking, with the exception of is if we are doing like a redo TAR or like a complex peristomal, or, you know, they have like a ton of medical comorbidities. But I think it's a little bit more nuanced than just like if you're smoking, you can't have a hernia repair. But with that, I will start my talk. Here. All right. So let me just go back to the beginning. I am talking about just leave it in, and I think it's an interesting topic for me. I will tell you, when I was a chief resident here, I took a patient back to the OR and they had a ventral hernia that was causing a bowel obstruction. They had multiple pieces of mesh in, and I called Dr. Rosen when I was done and I said, okay, this is what I did. And I was like, but there was some mesh in, and I just felt like it would destroy the abdominal wall if I took it out. And he was like, Charlotte, you'll never do that again as my fellow. And here I am now talking about reasons why you probably should leave mesh in. And certainly as I progressed through my fellowship, I was like, whoa, why are you leaving that mesh behind? You normally don't do that. So I'm just going to kind of talk about some of the nuances when you're kind of thinking about how to salvage mesh. Either it's mesh that you've put in, or you're seeing a patient that has been referred to you that has a recurrent hernia, and you're kind of trying to manage the mesh that has already been put in. As well as kind of go through some case scenarios. So I have no relevant disclosures. So I'm going to talk about what types of mesh should not be salvaged. Dr. Jignesh kind of talked on some of the properties of the mesh, and I think that that's really important to understand as to whether or not, you know, you can leave that mesh in and be okay, or if you leave it in, you're going to be stuck with complications down the road. Some of the mesh that's safe to leave behind, and where the location the mesh is, if that can kind of affect your ability to leave it in, whether or not you'll be able to salvage that mesh. And we're going to kind of discuss a couple of cases to kind of decide, you know, how we would manage these situations. So I'm going to start off with a case. The first case is a 53-year-old female. Her BMI is 34. She is a diabetic, has hypertension, hyperlipidemia. She has anxiety, and she actually was a smoker, but because of the complexity of her hernia and her poorly controlled diabetes, we told her she had to smoke and lose some weight before she could have a hernia repair. So she actually did manage to quit smoking. Her past surgical history was significant for a hysterectomy and a tubal ligation. And what we do is we always get the operative notes before we see a patient in clinic and get routine CT scans. And in this case, the operative note said that she had an internal hernia. So a hernia, but presumably no mesh that was left behind. So here's her scan here. And it's just like a huge caveat. Most of the reconstruction that we do are open, complex abdominal. So a lot of like very, very tar heavy, really not a lot of retrorectus. But I just want to point out something on her scan here. You can see when I was kind of reviewing this prior to doing her surgery, whoops, there was a little piece, like her abdominal wall just didn't look quite normal. On the right side, oh, it's not going to stop. If you can see it on the right side here, you can see there's like a little bit of waviness to her abdominal wall. And I like reviewed all of her op notes and I was like, this doesn't seem right, right about there actually. So, you know, presumably she only had an internal hernia, but when we went into the OR, we found a 4.9-inch piece of polyester mesh. It was pretty much only on the right side, and it was in the intraperitoneal position. So my question for the audience is, what would you do? Would you leave it in? And our plan was to do a TAR for her. So that was our plan. Would you leave it in? Would you take it out? How would you manage a piece of mesh, that type of mesh in that position?
So obviously, Charlotte, I'm taking that question. So a polyester mesh has no business being inside the peritoneal cavity, and there's going to be a breach in the posterior rectus sheath and peritoneum. So we got to take that mesh out and then figure out how to bridge that gap in the posterior rectus sheath and peritoneum.
Awesome. So that's actually what we did. So I'm going to start my talk off with saying infected mesh should always be removed in entirety. I think that, you know, there's, again, a huge asterisk to this. A lot of this is a lot of nuances, but if you are being referred a patient that has some sort of infected mesh, I think that it's the safest thing to just take it all out. Because again, op notes in this first situation may or may not be accurate. A lot of times you don't know what mesh is there. And although, you know, taking out a piece of mesh that's infected that someone else placed is a little bit different than kind of managing an infection of a piece of mesh that you have placed. So in general, I would say everything that's infected should come out. And when you're operating in a patient that you've been referred to that has an infected intraperitoneal piece of mesh or an onlay mesh, all of that comes out, all of the tacks come out, all of the sutures come out, because you kind of have to set them up for the hernia repair that they're going to get long-term. So, but some questions to ask when you're not being dealt with infected mesh is, when should you leave it in? And I think you need to answer these three questions. Number one, why are you operating? Number two, what type of mesh is there? And number three, where is that mesh? So first off, why are you operating? Obviously, an emergent operation, this actually patient far left is someone that's spontaneously eviscerated at home. So operating for an emergency, I think that, you know, addressing the mesh at that time is not appropriate. You kind of fix the immediate issue and say, listen, we'll deal with the mesh another time. If you're doing a planned elective hernia repair, such as in the middle, I think you need to be very cognizant about where the mesh is, what mesh is there, and it's probably best to take out the mesh the majority of the time. If you're operating for an infected mesh, and this mesh is actually from a TAR Rosen did 7 years prior that was now infected, in general, you should take out all the infected mesh. Again, nuances that are important to understand are, what are you going to do if, you know, you have done a TAR and it's just a small piece of mesh at the side that's a problem? What type of mesh is there? And we'll discuss some of those things as we move through the talk. So, as I had previously mentioned, the best way to kind of figure out if you can salvage this mesh is to know what mesh is there. Imaging, you know, it's routine for us to get CT scans preoperatively so we can kind of see where the mesh is and what type of mesh is there. Operative notes are always, or usually extremely helpful. But in general, when you're going to the OR to salvage a piece of mesh, try and collect as much data as possible. And so the second thing is there any evidence to suggest like how we should manage the mesh, which meshes will perform well even if they do get infected, or if you're doing a redo hernia repair and there's mesh there, what is going to happen to that mesh? And Warren et al. Out of North Carolina actually published a wonderful study that looked at 213 ventral hernia patients that the mesh did get infected. And they analyzed the mesh type, the location, they looked at all the patient and operative factors, whether or not those people were reoperated on and what type of reoperations they had, and they kind of stratified the mesh salvage rates. So I'm going to kind of use some of the stuff that they had mentioned in their study to kind of guide how we're going to decide whether or not the mesh can be salvaged or if we should go ahead and remove it. So the first thing is that mesh that can be saved, a barrier-coated or composite mesh in the intraperitoneal position is not one of them. These are the intraprosthetic fistula rates. And by far and away, the highest were a composite piece of mesh, and if it was in the intraperitoneal position. So I think, whether or not you have put that mesh in and it's infected, whether you are reoperating for an infected mesh or you're doing a recurrent hernia repair, if you encounter any sort of composite or barrier-coated mesh in an intraperitoneal position, that mesh has to come out. There's, the risk of having a long-term complication because of that mesh is just too high, and there's no way that, the evidence says that mesh should not stay behind. And in general, those meshes come out fairly easily, with a huge caveat to if there's any sort of polyester, sometimes that can cause a problem. But I think that in general, it is worth the potential morbidity you put to your posterior sheath to remove that mesh, if you can, or you should just remove it. There's no if you can, it's just kind of deal with the complications of mesh removal. What they did show here is you can see that the mesh that performed the best was always the macroporous polypropylene mesh. So I think that if you're trying to salvage a mesh and you know that you have either put in a macroporous polypropylene mesh, or you have a piece of macroporous polypropylene mesh already there, that's probably safe to leave behind and something that can stay there. Pretty much everything else will probably have to come out, whether or not, if you're doing a redo hernia repair, then you should just take it out at the beginning. If the mesh is infected, I would say if you're dealing with a heavyweight polypropylene mesh, sometimes we're able to salvage that with long-term antibiotics, debridement, and a wound vac. But oftentimes, when that doesn't work, that mesh gets cut out. And the easiest way to tell something that can be salvaged versus what cannot is if it's unincorporated. When you're kind of going back and debriding things, chances are that mesh is probably not going to incorporate. So cutting out the unincorporated mesh is something that you'll end up having to do to salvage the rest of the mesh that's there. So other sort of mesh salvage pearls. So when you are operating and someone has a polyester mesh, in general, that will destroy the posterior sheath. So when you're thinking about, whether or not I can save this mesh, or I need to take it out, if you're going to do a TAR and have a large defect in your posterior sheath, then you may have to kind of weigh the risks and benefits of kind of keeping that polyester mesh in. And something that you can kind of use to guide that decision is unincorporated mesh always should be removed. Well-incorporated mesh, it's probably safe to keep, and something that may be able to be managed. So let's move on to a second case. This case is a 45-year-old female. She has a history of diabetes, hypertension, GERD, and depression. She had a hysterectomy that was complicated by a pretty nasty surgical site infection that was MRSA positive at an outside facility. And because of that, they did some serial debridements, and she eventually developed an incisional hernia repair. And they actually did a simultaneous preperitoneal sublay and an anterior component separation, both with a Pro-C piece of mesh. She has been on and off suppressive antibiotics because she's had a chronic wound infection. She's had another IND after these meshes were placed, and she was on suppressive doxycycline, and she was switched to Vanc, and she actually had a recurrence of her cellulitis. So this is her CT scan here. You can see that there's a large fluid collection. She actually had a drain put in but came back to us because she had more erythema on her incision and her drain just stopped working. So my question is she has 2 layers of mesh. One is preperitoneal and one is an onlay. Would you remove only the mesh? And you actually, not on that scan, but there's a drain that's kind of sitting right in that pocket. So you'd be able to tell kind of which layer is infected. Would you remove only the obviously infected mesh? Are you going to remove the preperitoneal mesh only because that's right where the fluid collection was sitting? Or are you going to go through and take out all of her preperitoneal mesh and all of her onlay mesh?
Can
So,
we have
Ramana,
Rod Jacobs? Yes.
good evening, everyone. So, Charlotte, because it's pro-seed and it's got a coating on it, it's never going to get uninfected, unfortunately. And so if you can, technically, you should probably remove all of the meshes. But if some of the preperitoneal mesh appear to be well incorporated, then I'd be inclined to try and leave that behind. But she certainly needs to have the wound opened up, the onlay mesh removed, and then some sort of negative pressure wound treatment.
So what we ended up doing actually in this case is, as you said, like it was the preperitoneal mesh that was like the drain was lying right on top of the preperitoneal mesh. And unfortunately her preperitoneal mesh was like just stuck to her bladder. So we took out all of the preperitoneal mesh, and the onlay mesh actually looked like it was fairly well incorporated. So we ended up excising a large chunk of it that was obviously infected, but left a little bit of that behind. I honestly don't think the end of her story is there. And I wouldn't be surprised if at the end of the day, more of her onlay mesh has to come out. But again, I just wanted to identify some of the nuances that you're like, okay, well, this is definitely a pro-seed mesh. It needs to come out. But, you know, her mesh was so adherent to her bladder, very close to her iliacs. And we were like, well, maybe, you know, that mesh has to stay behind, and you kind of have to learn how to manage things that are technically safe and things that are, will require some expertise to kind of decide when you shouldn't leave the mesh behind. And these decisions are often very difficult. So I think, as seen in this case, in terms of mesh salvage, position matters. Again, as Warren and colleagues kind of demonstrated, if you have, this kind of looks at the first graph is the mesh salvage rates, and it was like a complete mesh salvage, and the graph table below looks at whether or not it was complete or partial, so it includes both. And as you can see here, the macroporous polypropylene mesh was salvaged 74% of the time, like complete salvage, and the macroporous polypropylene mesh was at least partially salvaged in almost 89% of the time. And these are patients that have actually had a documented prosthetic mesh infection. So I think it is fairly safe to say that if you have a piece of macroporous polypropylene mesh, that mesh could either be left behind when you're doing recurrent hernia, with some caveats to that. But in general, if you have a piece of infected macroporous polypropylene mesh, then opening, debriding, negative wound pressure therapy, and suppressive antibiotics is something that will probably get you into a situation where you can actually salvage that mesh. And I think our criteria for whether or not we need to kind of start cutting back some of that mesh is you kind of surveil these wounds over time. We normally see people back in clinic at least every 2 weeks, if not every 1 week, and then kind of hope to see that mesh granulate in. And if at any time the cellulitis gets worse, they start to have any sort of systemic signs of an infection, or you see that the mesh is not incorporating, then that's how you kind of determine what mesh can no longer be salvaged, and that mesh will come out. And oftentimes it does mean a recurrent hernia, but you've done your best to try to salvage that mesh. And that is a piece of mesh in a position that's probably worth salvaging if possible. So what to do when you encounter a piece of macroporous polypropylene mesh in the retromuscular space when you are doing a recurrent hernia repair. And I think in this case, a lot of times it's there because they've had a previous posterior component separation and or a TAR. And in that case, I think it's, you kind of have to decide what is the morbidity of taking that mesh out. And I think in these situations, a lot of times we actually do leave that mesh in, simply because, your posterior sheath is now very adherent to this mesh. Oftentimes, if you're operating just for a recurrent hernia, then it's probably, and it depends kind of where the defect is. If it's a lateral defect, chances are that mesh is probably well incorporated. So oftentimes we'll use that as the posterior sheath, simply because removing that removing all of that mesh can cause a huge defect in your posterior sheath. And so you're kind of stuck with a situation where you either have to bridge something because you can't get your posterior sheath closed, or you have to do a vicryl or a mesh on mesh situation. And that definitely has some operative morbidity to it. And I think, you know, it's pretty unclear as to what is the vascular supply of the posterior sheath. And so if you have a well-integrated, you know, it appears to look okay, piece of macroporous polypropylene mesh when you're doing a redo TAR, then that is actually safe to leave behind. The only thing I will say is we normally use a dissolvable suture to close that. I would use a permanent just to sew the permanent back to the permanent. So last case here, you have an 82-year-old male. He has a history of Parkinson's, gastric reflux, coronary artery disease, and he actually had urothelial carcinoma of his bladder. He's had a CABG and a robotic cystoprectomy with an ileal conduit, and developed a peristomal hernia. And we did the original peristomal hernia repair with a stratus piece of mesh. It was a keyhole peristomal repair, and unfortunately he had an early post-operative high-grade bowel obstruction and had to undergo an XLAP and lysis of adhesions. And he came back to us because he had multiple bowel obstructions, actually, and increasing pain. And we got a CT scan for him, and he has a recurrent midline as well as a recurrent peristomal hernia. Stratus actually looks really good, other than the fact that it's recurred. So my question, I can see Rod Jacobs saying something. My question for you guys is, what would you do?
Okay, Rod, are you saying something?
My comment was that the status.
Sorry, couldn't hear you. Could you repeat that?
He's still muted.
Stratus looked good, but it didn't work.
Yeah, so what are you going to do? That's the question.
I'd leave it with Dr. Rosen, but I'd probably redo the laparotomy, and you might want to reconsider resiting the ileal conduit. And again, you'd look and see what stuck to what and remove what you could and leave what you can behind and reuse what's there, especially if the stratus is looking like it's formed its own new fibrous layer. I wouldn't be inclined to take anything out that you didn't have to.
Would you put another piece of mesh in, or just use the stratus?
That's a great question, and I don't know the answer to that. I think I'd have to look and see what it felt like at the time. I've gone back in through.
Let's ask Sean. Sean, can you unmute yourself, please?
Hi there. Well, I'd have to see the CT again. I didn't see much of a midline component. Certainly the peristomal was there. And the thing is, with an ileal conduit, it's really hard to move the ileal conduit to other areas. So for many peristomals these days, especially ileal conduits, I try to stay out of the abdomen. In fact, I've been doing most of these as onlay repairs to avoid too much work in the abdomen. Oh, I see the midline component there. Yeah, you know, for this one now, seeing that lower midline there, I probably actually would go retrorectus and try to keyhole around the peristomal there. If they don't have any midline component, I try to stay away from the abdomen and just do an onlay with macroporous polypropylene, and it actually works quite nicely for ileal conduits because you can tighten that down pretty nicely, the defect itself, because it's only liquid going through there. It's not thicker other stool going through there for like a colostomy. And so again, it's just a way to avoid mesh in other areas and keep you out of the abdomen, and also keep you from messing around too much with the ileal conduit, because last thing I want to do is injure a piece of bowel, that conduit, with a very limited length. There's no excess like there is with an ileostomy or a lot of colostomies.
So did you say you would do retrorectors first, or did you say you would do onlay first? I kind of got confused.
So yes, so let me correct myself. Before seeing that lower midline component, I was just going to do an onlay, But now that I see that lower midline, so there's a midline ventral hernia and a peristomal hernia. So then I would go in and do a retrorectus and take care of both the midline component and the peristomal at the same time.
Okay. So would you do a TAR?
I don't think a TAR would be necessary for that. There's, when you talk about retrorectus versus TAR, there's the alpha carbonyl 2:1 ratio, which I think can be a useful guide. But at the same time, if I can get that fascia closed without the need for lateral dissection with TAR, I'll just stay with a retrorectus. I've had plenty of hernias that don't meet that 2:1 ratio, but I can achieve fascial closure without a TAR. So if I can avoid a TAR, there's just no need for further dissection. Even with a peristomal, unless that hernia is at the semilunar line, that is, if it is sort of mid-rectus, yes, I may not be getting 5 centimeters of overlap every single time or more, but if that hernia is not the semilunar line, it's hard for that hernia defect to expand out laterally. So I'm comfortable with keeping my mesh confined to the retrorectus space. That said, if that hernia is at the semilunar line and there's disruption there where it perhaps dissects into the obliques or out laterally, then I will do some degree of transverse abdominis release or get into the pre-peritoneal, pre-transversalis plane there to get wider overlap.
Okay. Shut up. Yes.
The other thing, that this is an 83-year-old with lots of comorbidities and probably a somewhat limited lifespan, and perhaps this is a case where 50's enough and 51's a waste.
Yeah. Well, so we went for it. Full disclosure, we did a redo TAR in an 82-year-old. And we were both, so I did it with Dr. Petro, pleasantly surprised that the stratus actually forms not a lot of adhesions. And so doing a redo TAR, and I think this is one of the first ones that they have done at the clinic. It was kind of nice to not have to leave a plane basically. So, and we ended up actually, there was enough length on the ileal conduit that we actually sugar bakered the conduit and put in just a small 30 by 30 centimeter piece of medium weight macroporous polypropylene mesh. So the reason I present this case is a lot of times there isn't a lot of data about what to do when you encounter these biologic or biosynthetic meshes, and can they be salvaged? There really is a porosity of literature as to exactly what to do. And I think, there has been more than once that we have gone back and done a TAR on a patient that's had phasics that's been there for well over 2 or 3 years, and it's still there. And so, truly how long these meshes last and how they act is still something that I don't think there's a lot of data that can tell us exactly what to do. But I think that in general, if they're not infected and they look like they're, well incorporated and doing the job that they should, they can probably be left behind. Every single time we're taking out a piece of phasix, it's because it's kind of balled up in the abdominal wall, not in the right position. And sometimes it can be utilized as the posterior sheath. So I think that, until there is a lot or is, evidence about what to do and how to salvage these biosynthetic meshes, probably err on the side of taking them out if you can. But in general, if it looks healthy, well incorporated, it's not infected, and there's a significant morbidity associated with taking it out, then, it's probably something that is safe to leave behind. And hopefully, eventually we'll have some data that kind of helps decide what to do in these situations. So in summary, I think all infected mesh should always come out. Well incorporated mesh is probably safe to leave, whether or not you are kind of managing a long-term wound infection or you are doing a recurrent hernia repair. If you can get that mesh to incorporate well, probably you will be okay. And in general, when you're kind of reoperating or doing a recurrent hernia, you have to kind of decide the risks and benefits of leaving that mesh in. I would say leave the mesh in only if the risks of taking it out greatly outweigh the benefits. So if you're going to have a huge defect in your posterior sheath, any sort of other injury to bowel, bladder, or vasculature, then it's, that's probably safest for the patient to leave that mesh behind. But do everything you can to take that mesh out if it's safe. That's it.
All right. thank you very much. That was really a very, very nice talk. And I open the floor to Sean, our expert, to give us his views about both Jignesh's talk as well as Charlotte's talk. Sean.
Well, good morning from Portland, Oregon here. I guess it's afternoon, evening there in India. I want to thank you for the invitation, Ramana, and happy Independence Day to everybody there. Wonderful talks by Jignesh and Charlotte. And Jignesh, I love all the science that you showed there. That's one of my passions, is not only what I used to do back in the lab, but seeing and learning new science as it relates to hernia repair and mesh in general. Both talks just gave a wonderful amount of information for hernia repair in general, as well as with mesh. A couple things that I was taking some notes as both talks were going on. Something I'd like to highlight that Jignesh already talked about, and that's about having a flat mesh, whether it be at the time of implantation, what can happen if that mesh becomes unflat, if you will. And this relates a lot to ventral, but that also translates to the groin repairs as well. One of the things that can happen is, he talked about mesh contraction. And one of the side effects of mesh contraction is that if that mesh looks perfectly flat upon implantation, you get mesh contraction. And depending on how that mesh is fixated, or depending on how it's situated in that tissue plane, as it contracts, a lot of times at the edges, you get the scalloping of the mesh. And when that mesh goes from 2-dimensional flat to 3-dimensional, that's when you tend to get a lot of adhesions and problems. You get increased scarring and fibrosis around that. And that's where you tend to get a lot of problems. And the best example of this is with a lot of composite meshes with, say, EPTFE as the anti-adhesion barrier, and then you have a polypropylene component of it. Well, those two materials have different rates of contraction. And you'll get increased contraction of the deeper PTFE mesh, and that scallops the edges and shrinks down, and then exposes raw edges of polypropylene mesh. And that's why you get all these adhesions around the outside of that. You get mesh erosion, sometimes fissilization with a lot of those particular composite meshes. For IPUM meshes, fixation is crucial for those. And if those edges aren't perfectly opposed to the abdominal wall at the time, and then that can again be exacerbated by mesh contraction, that can lead to some problems. So I think a good attention to detail when an IPUM mesh is being placed can at least reduce the risk of those sort of nasty adhesions and problems at the lateral aspects of the mesh. But that sort of concept gets translated into the groin. And that's why there's a good recommendation from European Hernia Society and the World Hernia Society guidelines as avoidance of 3-dimensional mesh in the groin, avoidance of mesh plugs, Prolene hernia systems, and the sort. And the whole idea is those 3-dimensional structures create a lot of inflammation and a lot of fibrosis around it. And that in turn can lead to either chronic pain down in the groin or mesh erosion and other complications related to mesh. And don't confuse those 3-dimensional meshes with contoured mesh. There's 3D Max, which I tend to use a lot of. That's just a contoured mesh. It's really a flat sheet that's slightly bent to fit better in the groin. That is not the same as a bilaminar mesh or a mesh plug. So that's my thought about trying to keep that mesh as flat as possible. Now, the last thing about that, which is interesting, is I use a lot of macroporous polypropylene. That mesh can actually tolerate a lot of folds and overlapping. So that particular mesh, I don't have any problem overlapping with its own self. So when I do a lot of TARs, I plate a lot of home plates where I have overlapping of macroporous polypropylene. Or for example, if I have a little extra at the edges and they fold over, as long as they fold over flat and collapse on itself, it's probably not going to create any of those issues I talked about with 3-dimensional mesh.
Do you think transfascial fixation when you do your TARs is important? I know this is becoming very controversial now.
That's the golden question that's been debated for the last couple of years. That's a good one you got me with, especially since you're going to be joining Eric Paula there, or you are joining, excuse me.
I'll tell you, we fight or we argue about this all the time because he does something very differently than what people are doing at the clinic, and so we always talk about what's going to happen when I get there.
Yeah, I'm actually love to see all the infighting that you guys have with that. So, it's funny that the argument with that is that, when I was a fellow at Case Western, I trained with Mike Rose and Neri Nowitzki, and both have similar, concept with hernia repair, but there are also some stark differences. And one of the big differences is in transfascial fixation. So I was lucky enough to get the best of both worlds. And I've been a fixator for much of my career. But that said, I actually have been drifting away from too much fixation. So to answer your question, for TARS, I really don't do too much fixation these days. I still do if I feel like there's some tension on the fascia, before I approximate the fascia, then I may do some lateral fixation. I really been trying to get away from excessive fixation. Retrorectus, I do still like fixation for most retrorectus, just because I think there is a little bit more tension on both the posterior and the anterior fascia. So I tend to put maybe one top and down and 2 or 3 on each side for retrorectus. Unless, sometimes we get these nice retrorectus, which are like 10 centimeters on each side in these older patients with stretch out abdominal walls, then I do avoid it for those particular cases. So I'm kind of mixed, but I've been evolving. Ask me that question again, Charlotte, another couple of years, and we'll see if how my answer changes. It's also hard when I'm getting crap from my friends and colleagues that give me a hard time about putting fixation in. So.
All right. So Jignesh has some case scenarios. Let's see what's he got.
Okay.
So Jignesh,
so before I just start that,
already. So just try and make it a little compact.
Yeah. So I have about 8 to 10 cases, and just before I start with that, the comment to Sean is a lot of us. I have seen the literature and the discussion of the AWR group. Whenever I have seen a problems happening with the mesh moving around or a recurrence, it's always post TAPP. And my perception is that the TAP surgeons probably see the folding and the relationship of the mesh and the bladder better compared to a TAP surgeon. That's what I feel. And that's where the folding concept, which I mentioned about when the bladder gets distended. So maybe it's true or it's not true, but this is just a food for thought. Let's come to the second part of my talk, where I'm going to talk about the mesh cases one by one. And we will start with our expert panel. We've got Danny, we've got Dr. Rod, Sean, Dr. Ramana, Charlotte. So I'll probably go one by one to each one of you. That's my case number 10. So this was a gentleman who had, so maybe I'll start with Danny. Danny has been quiet for some time. So Danny, this was a gentleman, I could get the pictures. He had undergone a hybrid procedure for an ETEP about a year back. And this is a patient here. So these are the pore placements where you can see that. And this was an uneventful surgery with a huge amount of momentum stack, which came out that. And you can see this is 1 year later. So as we keep coming down, he came with pain in the right groin. There was a small wound there. He had excruciating pain, and this has typically happened during the lockdown period in Mumbai. And then he said that he was in a lot of pain. He could not tolerate that. He was getting fever. So he was getting treated and worked up for COVID. Then he said that he's got a small pustule in the right groin. And as we come down there, you can see in the right groin area, so this is where the stranding starts. These are the fixation tags. And you can see there's a first collection of the fluid there, which is the TEP component. And there's a large collection over there, which is on the outside. And this is where it was communicating with the skin, and there was a small opening when I saw him. So how would you like to proceed in this case, Danny?
It seems that with such a large collection on the outside, you have to go open. But this retromuscular mesh infection sometimes do better when you go from inside. And I think I may have explored him laparoscopically and get directly to the mesh, because that's a problem. So if you can go inside and look at the mesh area, open the abscess there, and remove the mesh, sometimes it's quite easy to remove. It's not that stuck because it swims in a pass. Then you may have a solution without opening the groin. And then you can add some counter incision just to complete the external drainage. So I may try that.
Okay, so Rod, the question to you: would you like to do this from outside or from inside?
And look, I agree with Danny. I'd probably look on the inside, but he certainly needs to have the external component drained. And then I just perhaps wait and see. But yeah, sometimes they are easier to pull out internally.
Okay. So what typically happened was, since I saw the major component was outside, when I took him up for surgery, and I always feel that Mother Nature has been kind enough for him to, extrude the whole thing. Let us see what happens from outside. And what typically happened was that we could go very comfortably inside, and we had kept the hybrid plant ready for this patient. We went ahead with the explant from outside, and this is where you can see the entire mesh coming out with all these tackers intact. It was very easy to go from outside because it was already pointing out at the deep ring. Retrospectively, I felt that if I would have from inside, I would have probably opened up the peritoneum and damaged and made that contamination, because I'm going to discuss another case. So this case probably tells us that if major component of the fluid tracking is outside, one should probably try from outside and see whether you can get ahead, because you've got a nice seal. You know the history, that there has been an ETEP procedure done. There is no breach of the peritoneum. Coming to his culture reports, he grew MSSA positive culture, AFB negative, atypical negative. Dr. Sean, what would be your antibiotic protocol for this gentleman? Sean, are you there?
I mean, if somebody is just for MSSA, non-MRSA, that's a standard ANSEF or cefazolin.
Okay, because for an Indian scenario, most of the times, Dr. Ramana, any comments about atypical?
Well, typically these have atypical mycobacteria because of reuse of tax. We all know that. I think this is pretty much common. You have to remove those tax. And
yeah. So in this case, Dr. Ramana, I did ask the primary surgeon, and it was a 15 new one which he had used. So probably, are we happy at 1 year just having a positive report of MSSA, treat for that, and that's it? Or you need to still put him on treatment for atypical?
I would lean very heavily on atypical. I would definitely do that.
Okay, fine.
Otherwise, you would rarely have an infection in TEP.
Right. Okay, so coming to the next case, this is a story of a young boy. Charlotte, probably you can take this case. Story of a young boy.
Jignesh, we are live on Facebook, so please don't show any genitalia, okay? We'll get thrown out of Facebook.
Okay, no problem. So I have covered up everything, don't worry about that part. So story of a young boy, open groin hernia repair. 3 months later, he gets a wound discharge from the wound. He's put on antibiotics, there is no response, so the surgeon decides to explant the mesh. Now he puts in a new mesh at the time of explantation, which is very surprising, and he puts on a macro. Months, the boy is moving around with the drainage bag. And can you hear me now?
I don't know if it's me or if it's you. Everybody else okay? Yeah?
Can everybody hear me?
Yeah.
Now you're
There's
back.
a little problem in that, but it was there now.
Okay, fine.
Okay, it's fine. So this is what happens in short, and this is what is happening, Charlotte. So what happened? So he came to me with this picture there with the drain, which is draining for 6 months with this discharge there. How would you like to proceed, Charlotte?
How much is the drain putting out?
It's about 50 to 100 mils per day, and it is clear serosanguinous, but he's moving around with that. He's got no fever, no spikes. You can see no inflammation, but it's about 50 to 100 mils per day.
You know, I would probably just go back and take. He looks relatively thin. Go back, take his old mesh out, take the drain out, and just do a tissue-based repair.
Yeah. So this is what even I planned, and then the mesh was explanted completely. It was just floating there. I do have a CAT scan, but it was floating there. This was its wound on subsequent dressings doing after that. But the point which I want to make here is that typically when you have a track like this, I feel that we should follow the principle like malignancy about seedling, because in case if this patient has got an atypical organism coming in, please excise also the sinus tract. As you can see here that I've gone ahead and even removed that, because what came out later on, this is what was the wound like, and this is later on, was that he grew atypical, and then he had to be on a treatment for almost about a year. So the message from that case is that please try to remove the sinus tract, otherwise you can have a trouble. The next case, Rod, probably you can take up that. Groin hernia,
We have
60-year-old
Rakesh
gentleman.
Khattar, Jignesh.
Yeah.
We have Rakesh Khattar
Yeah,
waiting.
So we can ask Dr. Rakesh. 60-year-old gentleman, this is a case courtesy Dr. Rahul who had shared this patient who had come to him from someone else. Bilateral TP done in 2015. And 5 years later, this gentleman comes with pain in the right groin and fever. Pus is aspirated and the cultures show a positive growth. And this is a patient, and this is his CT scan. So Dr. Khattar, if you would comment on that. So bilateral TEP 2015, and there's one collection there. You can see the rim of collection over there. This is again a case post TEP, but you saw that case and you're seeing this case now.
I think in this case, mesh needs to come out, and there
yeah,
is
so the descent number one. I can't hear you clearly, Dr. Khattar. Are you going to aspirate, operate, remove the mesh, not remove the mesh?
Yeah, that is what I'm saying. The mesh needs to come out, and don't put in a new mesh, and that's it. Mesh needs to come out.
So what approach? What approach?
Laparoscopic. Laparoscopic
approach. Okay. So this is where the mesh was removed by laparoscopic approach. And I and Dr. Rahul had discussed this case. Typically for, most of our Indian surgeons who are watching, it's always a good idea, which also I shared with Rahul, is to remove this granulation tissue, which always hangs in the cavity. This is typically a picture of an atypical. Just draining the pus is not going to help us out. We need to remove all this unhealthy granulation tissue 360 degree and then send all of this for culture, because only going to remove the mesh is not going to help. Typically in the literature, it is also mentioned that atypical somehow has got
we have an international audience.
Fluid has got a good, yes.
We have an international audience.
Yeah.
You have to specify it's atypical mycobacteria. They wouldn't understand otherwise.
Yeah. So atypical mycobacterium, what I was talking about, always has the cavity which is surrounded by this unhealthy granulation tissue. So it is not only draining of the pus, but also the cavity has to be scooped out completely, because otherwise this patient stands a very high chance of a formation of the sinus. This is typically his report. Dr. Khattar, any comment? He's got most of the stuff resistant, only susceptible to doxycycline. How would you manage this patient?
Yeah, I would put him on long-term doxycycline.
Only single drug therapy?
Have you taken out the mesh?
Yes, the mesh is already out.
I think then only single drug therapy should be, maybe for a week or two, you can give him antibiotics which have not been tested, and then you can put him long-term doxycycline. That is what I would do. Short course of drugs which have not been tested in antibiogram, and then a long course of doxycycline.
Okay. So just for the knowledge for everyone, for the atypical mycobacterium, because it's a surgeon's nightmare, this is an article which talks about looking beyond for the treatment of atypical mycobacteria. There are slow growing, which grow in about 7 days, rapid growers in less than 7 days. They usually come from the soil or the tap water, which is the common source. The slow growing are Kansasi and Xenope. The rapid growing ones are abscesses, Chiloni, Fortitium, which was typically in this patient. So these are fall into the category of non-tuberculous mycobacteria. They're resistant to chlorine-based solutions. So it's very, very important when you have such a case that you need to sterilize your instrument very, very properly. These are hydrophobic, strong adherent property, and they can form a biofilm on the implant. So one has to be very, very careful when you're putting in the mesh, and they can grow in a compromised environment very, very well. The first line of treatment for a typical mycobacterium always remains a macrolide. In addition to that, a combination of ethambutol along with rifamycin. I usually put my IED specialist into the picture, but remember the treatment duration is sometimes from 6 months up to 1 year. The second line of treatment for this is aminoglycoside. I use a lot of amikacin dressings locally, and it works very well. It is established in the literature as well that you can use topical application. Quinolones is also added in the second line along with clofazimine, which is a very good drug for skin and subacute atypical, which was used for leprosy in the past. And linezolid also works very, very well. So are the other drugs. And these are the newer drugs which are now being given into the literature. One just needs to know about them. There are a range of them which are used for atypical. This is just algorithm to talk about that. So more and more drugs are now coming up for the treatment of atypical. That's for the benefit of the audience. So coming to the case number 7.
Before that, Jignesh, I have a question.
Yes.
You have an infection like that 5 years after surgery. Do you think it's primary infection still? Or
yeah, it's primary infection. It's a primary. No, I think it's a primary infection because this is a typical slow growing. Probably the nidus or the inoculum of the colonizer was very, very small and over a period of time. So we've seen patients coming in after 2 years, 3 years, 4 years, and they really take a long time to come from there. I think it's the host immunity which plays an important role. If the patient's immunity is relatively good, the delay in the clinical manifestation is always very, very delayed. And that's what we have seen in a lot of patients with atypical mycobacterium.
Yes, I also want to ask the same question. Why late infections occur after 5 years? And
so this typically is because of the good host immunity and a small inoculum of the atypical. So it was not a large volume inoculum of the atypical, probably on one of the tacks or maybe the sutures or the place where the mesh was implanted. And then it slowly starts forming a biofilm. And the problem is that the patient keeps on having subclinical infection. But over a period of time, the infection becomes quite bad when the immunity of the patient is goes down, and that's where they come up with such major problems.
And is it always
coming to the next case?
Is it always atypical?
Yeah, most of the times, if you see, the cultures would grow in about 27% of the patients.
Jignesh, I'll have to interrupt you now. Jignesh,
yeah.
I'll have to interrupt you.
Yes.
Please don't show any groin cases anymore. We don't want anything going on to Facebook. Please go into other cases.
Yeah, but I have covered most of the things.
Make it faster, please.
Yeah. So this was again a patient, courtesy Dr. Rajesh. He had shared with me. Maybe Danny can comment about it. Open mesh plasty in 2011. He underwent later a suprapubic cystolithotomy for a large bladder stone in 2013. And then typically the patient said that he's got some discharging sinus and thread-like material, which is coming from the suprapubic scar in 2019. So it's about a decade-long story. What's happening, Danny? Danny, are you there? Maybe I would probably dedicate it to Sean.
Hi there. So with a chronic, sounds like a chronic draining sinus after a previous mesh placement.
Yes.
Step one is getting rid of any source of infection. And you know, when I was listening to the talks from both you and Charlotte, I think one of the big sort of things, especially with ventral, but it also applies to the groin though, is staging your repairs. I think there's an aggressive approach for some people. They want to remove the infection, fix the hernia right then and there. I'm a little more conservative where I like to stage these out, where to me, step one is just getting rid of any source of infection, whether that be removing mesh, all permanent sutures, all chronic draining sinus, the sinus tracts themselves, doing as best debridement as I can of all good tissue, and then primarily closing that hernia. You know, if I have to bridge that with a biologic or a bioresorbable mesh, I'll do that at that time. And the whole goal is get rid of all the source of infection, temporize the hernia and can then come back to fight another day. That is, I don't want to burn any bridges from that first surgery that I do by burning up different tissue planes in my retromuscular plane. So step one is cleanup job, remove all foreign bodies and infection. And step two, whether it be a few months or a year or whatever it is down the road, then I'll commit to a more formal abdominal wall reconstruction procedure. And at that time, I probably have more choices for mesh. Perhaps since I've cleared that infection, if there's no ongoing infection, then I can use hopefully a permanent macroporous polypropylene mesh.
And we have to also remember that not all cases recur. So if we remove the mesh and do a primary repair, many of these cases will just stay fixed.
Agreed. So in this particular patient, what happened was investigated, and there was a mesh which was eroding into the bladder. So I typically talked about the science lecture where there is a weakened area and probably the mesh has migrated into that. So it had formed a stone also along with that. So the mesh was explanted from the bladder along with the stone, and the patient had an uneventful recovery. So this is again a next case, victim of ETAP-RS. Maybe I would request Rod or Sean to comment on this. Typically, we all know that when we are doing an ETAP-RS procedure, the crossover is the Achilles heel, and we've all gone into that problem. This is typically a case where while doing the crossover, what the surgeon has done is he has completely lost his plane and he has landed up into this zone. This is what has happened at the second surgery. The patient has come back with a recurrence and the mesh had to be removed. Sean, you can just see the video. The surgeon is in the subcutaneous plane, the second surgeon now, and this is what he's showing us. So your comments on that, the mesh is on the opposite side, but it is all in the subcut plane. So there is no infection, but the mesh needs an explantation. Yes, Sean.
Yeah, I mean, absolutely. This mesh, it's a non-functional mesh at this point. It can only cause harm. It's not providing any benefit to the patient. So the entire mesh and any sutures that are used for it need to be removed.
So typically, for the audience, this is a classical case where the mesh has to be explanted because of a technical reason that the surgeon went into a complete wrong plane. A TAR was offered onto this patient, and you can see that it's done pretty well, and this is the end result of the case later. This was another patient, Dr. Rod, if you can just comment on that. This patient had a 1.4 centimeter umbilical hernia, okay? And the surgeon decided to do an ETAP-RS, and now this is what is happening after 6 months. On the CAT scan, it is showing a 12 centimeter defect. Is it a technical failure, or should we call it as a recurrence or a surgeon's signature? Yes, Dr. Rod,
Well, it depends.
Your comments.
It depends upon how nice you want to be to the other surgeon. But he's used a bulldozer to dig a small hole to plant a rose bush. It's just he probably should have done a different procedure.
Yes.
Now he's got a bigger problem, and to repair it's going to require at least a retrorectus repair, possibly a TAR. I don't know. I'd have to look at the scans, depending upon how wide the rectus muscles are, and whether that's done minimally invasively or as an open procedure will depend upon the skill of the surgeon. But if I'd been doing it, I would have done probably an open operation through a small incision and put the mesh in the retrorectus plane at the first surgery. But sometimes I do these laparoscopically as well.
Okay.
And of course, you can make a case on a 1.4 centimeter hernia just closing.
Let me ask Rod, okay. Let me ask you, Rod, if the patient is saying that he is asymptomatic, would you just leave him alone?
No, I think the problem is that's going to become a 15 centimeter wide and then a 20 centimeter wide defect over time. It's just going to get bigger and bigger, and it will become symptomatic.
Okay.
And Todd Hannaford's recently shown that watchful waiting whilst it has its moment, it's no doubt to get bigger more often than not.
I agree. This is not an asymptomatic abdominal hernia. This is disruption of the abdominal wall. So this should be fixed.
So I thank Dr. Chetan for sharing, because this patient was referred to him, operated by some other surgeon. And he was in a dilemma that the patient is saying that, doctor, now I have a bigger bulge. I do not have many symptoms, what to do. So we were in a little dilemma about what has to be done, but I think you've given a clear message that this is going to become bigger as the time goes. Coming to the next case, I'll probably put it up for, so I think we will avoid this groin cases. This is courtesy Dr.
Just
Punjani.
take one more case, Jignesh, and keep the other cases for another session on complex hernias.
Yeah. No problem. So I'll just go through this. We've got something more. This is again an explanted mesh, Dr. Punjani's case. Yeah, so this is a little interesting. This is post-IPOM. 3 months later, patient has got pain and fever. So, Sean. Patient has undergone an IPOM. 3 months later, the patient comes back with pain and fever. And I think even I would like to have a joint comment by Charlotte a little later. The mesh has to come out, or she wants a mesh to, salvage this mesh. Yes, Sean.
Just to come out.
Comment first.
There's fluid collection. Now, people can develop chronic seromas from these, and in them by themselves aren't necessarily dangerous, but fevers, chronic fluid collection, with or without sampling of that fluid, there's a good chance that's an infected seroma in that, and that mesh has to come out. Little chance of salvaging that mesh. So I would go in there, do a full explant, culture it just to make sure I get the right antibiotics for it, but otherwise, debride any tissue that's bad and get rid of tack sutures. Primarily close it and come back to fight another day should the hernia come back. What's interesting about that is that one of the reasons why most IPOM meshes, composite meshes, are challenging in the setting of infection is that anti-adhesion barrier. They're carbohydrate-rich structures, which are fodder for bacteria. So if those get contaminated in any way, there's very little chance of salvaging that mesh. As opposed to non-coated meshes, especially in the retromuscular plane, the macroporous polypropylene are very tolerant in the setting of infection. But infected IPOM meshes, especially depend on the material like polyester, or if there's any PTFE, that's game over. It's got to come out.
I think it also depends on the cover itself, because if you use collagen or hyaluronic acid, then it dissolves. If you have PTFE, of course, it has to come out.
Okay.
I think regardless, that mesh has to come out. I think the only other maybe nuance, and I would definitely agree or state that this is pushing the boundary, but if you got into a situation and you saw that mesh and it was probably just like a chronic seroma, you could argue that you could do a definitive hernia repair at that time. We definitely have had conversations in the OR about doing it. Personally, I probably wouldn't, but I know that, it may or may not be okay, depending on what you find in the OR. So that, there's definitely, maybe you could argue on the fact that if it was just like a chronic seroma, and it's a sterile culture, could you proceed with the TAR? I think, more than likely no, but, sometimes it is a possibility.
Okay. So this is what was found.
Yeah, I'm like Sean. I favour stage procedures. I just think that they've already had one problem. It's better to come back another day.
Especially since it's IPOM, so you can go laparoscopically, remove it completely, and then you don't do anything wrong to the abdominal wall. You can keep everything to the next operation.
Yeah. Jignesh, this is relevant to what you said in the initial part of your excellent talk. You're doing an IPOM and you're getting a bad infection which necessitates an explant and subsequent complex hernia development and then resurgery, etc., etc. The question is why? So among the factors which lead to this, one of them is mesh type, as you mentioned. So we all know now that PTFE is one substance which doesn't tolerate any kind of infection, and if you use a PTFE mesh, then this is an outcome which will come up at some point of time. There's another mesh, and I suspect that many people may not have any experience about it. I do, so I'll mention it. There is or was a certain brand of mesh, which is, I think it was just basically polypropylene coated with omega-3 fatty acids, marketed as Secure, C-Q-U-R, by Atrium. That mesh has a very high predilection for infection. And in fact, I had 3 mesh infections in a row. So I had a hat trick of IPOM mesh infections back in the early 2000s. So just mentioning this factor of the mesh itself being a predilection or a predisposing factor for infection.
It was also very stinky.
If I can
Yeah,
piggyback
and
on that, the problem with certain newer meshes like Suture, which luckily is not being used, and there's actually active lawsuits going on for that, is with IPOM meshes, you want to facilitate ingrowth from the peritoneal side, which already has a limited ability to ingrowth. And if you cover mesh fibers with any substance, whether it be omega fatty acid or with physio mesh where they covered it with monocryl, you limit ingrowth in there. That limited ingrowth can lead to other problems like chronic seroma, lack of integration, and if that fluid gets infected, again, you're going to have a hard time clearing that. So
my question is whether only mesh gets infected less than retromuscular and IPOMs. Is only mesh placement safer than other 2 locations?
No. Well, each tissue plane has its own risk-benefit profile. So the thing is, as Ragnesh already said earlier, the closer you are to the level of the skin, the more potential for skin contaminant or skin flora to get infected that mesh. I do not think that onlay is safer than other planes. Retromuscular is probably the safest plane because not only is it further away from skin, you're adjacent to well-vascularized tissue. You get better neovascularization, tissue ingrowth. You're going to be able to get over an infection easier. Whereas with an IPOM mesh, you have very little ingrowth, even though you're further away from the skin. So again, each tissue plane has its own pros and cons, but retromuscular plane has been shown to have the lowest incidence of infection and greater chance of mesh salvage.
Okay, so Jignesh, we'll stop with this.
Yeah, I think it's just just one. If you don't mind, can I just discuss one case scenario because that is useful for the audience. Maybe I'll just pick up that case as a last case. Maybe I can have a comment. This gentleman had undergone a scola about a year back, and now he's come back with this. So, this is the CT scan. I'll just rush to the CT scan for all of you. It is about a year back. No fever, nothing, no tenderness. He's come with this a year back after scola. So let's start with one comment from each one of you. Let's start with Sean. What would you do?
The chronic seroma, you can try to drain it with an IR drain, but that looks like a pretty thick rind on it. So you probably have to do a capsule resection of it. I would certainly sample it for culture, but I don't see any evidence of stranding or other signs of infection. So probably just removal of the seroma cavity and more for future note to make sure that if you do a scola or any onlay approach, that plane needs to be drained for a long period of time to reduce the chance of seroma.
Okay. So Danny, just aspirate the fluid or laparoscopically open up, remove the fluid or remove the cavity in total.
Give it one chance of percutaneous drainage, and if it recurs, then I go in laparoscopically and try to eradicate the cavity.
Okay. So what we did was, if you see the chronicity, the chronic seromas usually would not get amenable. This was a nice cavity forming there and everything was inside that. And you can actually see the mesh here, which is right there, and that's a huge seroma there. So the message is, if you have a chronic seroma, I think it would be a good idea to go and remove the cavity with the mesh completely. Only aspiration probably will work in the earlier stages. And you can see here how thick is the cavity of the seroma after we remove that. And this was a well-formed sac. This is the end result. The patient did pretty well, and he did not have any recurrence of the hernia. Little later, we followed him up for a couple of months after that. So probably I think I'll end my case scenarios there. I had another last case, but it's fine. So just to have my concluding take-home messages from all this discussion we had today, mesh infection and mesh explantation is to be taken very seriously. I think one should have a deep knowledge about the science behind it. As you learn that, understand more about the mesh and the tissue interaction, and remember that after you have done a mesh plasty, follow for at least 3 years, because this is the time up to which the mesh can get explanted. And please study the explanted mesh as a surgeon along with your microbiologist or the pathologist, so you can understand better what is happening. So in future, it is a learning for you. And finally, once you have gained all the knowledge, imaging is the key. Keep the microbiologist and the ID specialist with you all the time. And especially in the Indian scenario, a typical mycobacterium still plays an important role. So we need to understand the nuances of the latest guidelines and treatment management. Thank you very much, all of you. And it was a wonderful panel. And back to Dr. Ramana.
Okay, concluding remarks from every one of you, please. Charlotte?
So just as Dr. Jignesh says, I think that when you're kind of deciding whether or not to explant or salvage a mesh, that it's really important to understand mesh characteristics and mesh location. Those can really kind of guide your decision as to whether or not that mesh is salvageable or not.
Danny?
I think we've learned that there are many factors here, and I think that one of the main messages should be what Charlotte said in the beginning, that we should always remember that there's a difference between significance and clinical significance. And also regarding science, we have to know the science, but sometimes when you're facing a patient, it's only a clinical decision.
Okay, that's interesting. Sean?
Thanks again for having me. I would just say that, know your mesh. There are different mesh. Each hospital has the ability to have sometimes multiple meshes, or they're contracted. So you really got to know your mesh at hand, or work hard to get mesh that you think is the best for your patient. And then also just don't burn bridges. If you can avoid big operations on people that don't need that big operation right now, try to do that. And with that one case, the ETAP case showed, you don't need a sledgehammer for a tiny little hack.
Right. Rod?
Ramana, thanks for the invite. It's been a great evening. Yeah, I agree. I think even though there are some principles involved, that you've got to make your decisions on a case-by-case basis and not be too dogmatic about what you should and shouldn't do. And if you're listening in a few weeks' time, I'm going to give you some hints as to how you can avoid getting wound and mesh infections anyway. So hopefully we can do that.
Okay. Rakesh? One vote for only, once more. Nobody's talking of only.
I think onlay is a good operation if it's. I think onlay is a good operation if it's done properly, but very few people do it properly.
Yeah. So
it has its place.
Onlay's all right.
You need to unmute yourself. Can somebody unmute Rakesh, please?
Yeah.
Yeah.
Yeah. What I'm saying is every mesh infection has to be clinically assessed by CT scan, and then treated conservatively at the first go, unless the patient is going into sepsis. In that case, you have to take aggressive measures, and many meshes can be salvaged. That has been my personal experience over the last so many years, especially on the onlay positions. And the 7 to 10% mesh infections quoted for ventral hernia repair, I think it is an excessive figure, and these rates are much lower.
Okay. All right. So
just one last thing, Dr. Ramana, I would like to say that we all surgeons are good with laparoscope. Dr. Parveen Bhatia is here, so we are good with laparoscope, but spend some time behind the microscope. So we are good with laparoscope. Let's spend some time behind the microscope and understand things better, so that we can give good clinical outcomes.
All right.
Yes, Dr. Ramana.
I think
Thank you.
we'll wrap it up today. It's been a very interesting Saturday evening. And don't forget that every Friday, we'll be bringing a smart talk to you, and we will have as good a session as tonight. Thank you, and have a very, very good weekend. Bye.
Happy Independence Day.
Thank you very much, Danny, and thanks to all the foreign faculty, Charlotte, Danny, Sean, Dr. Rods. Brilliant. Thank you so much.
Thank you so much for the invite.
Sean, Charlotte, stay safe.